Hello, my name is Thomas Lee, and I'll be talking about lung ultrasound and COVID-19. I'll go through some indications to use lung ultrasound in kids with COVID-19, which probes to use, how to acquire the images, what some normal anatomy looks like, as well as some pathological findings, the pearls and pitfalls and pros and cons, and we'll go through a case together. You can perform a lung ultrasound for tons of indications, but most common are significant respiratory distress, fever, cough, tachypnea, and hypoxemia, and when you're really not sure of the diagnosis. Generally, the best transducer to use in pediatric lung ultrasound is the linear transducer. That's because most consolidations are subpleural, and you tend to get the best images with this transducer, since you're trying to focus right at the pleural line. Of course, if you need greater depth, like if you're looking for an effusion or a larger patient, you could try the curvilinear probe. The other commonly used transducer for lung ultrasound in pediatrics is the curvilinear transducer. And that again is used in patients with a larger body habitus or those with significant MSK or chest wall abnormalities that a linear probe might be harder to navigate. Again, you could use any standard setting, any standard lung setting on this transducer. And again, you're trying to get the same depth as the linear probe, which is right at the pleural line, because that's where you're going to see most of the pathology. To acquire the images, you can really be obtained in any position, either supine or upright. And what you're trying to do is visualize each hemithorax in the anterior, lateral, and posterior regions in the sagittal and or the transverse planes. You almost never really need any special settings on the lung ultrasound machine. Every now and then you might need Doppler if you're not sure if what you're looking at is hepatization of the lung or liver, in which case seeing flow can help you distinguish whether or not it's liver. And generally the gain should be well balanced, so you don't really need it too high or too low. If the patient's critically ill and you can't really see the posterior zones because they're supine and it'd be unsafe to move them, you should at least do axillary and the posterior basal area around zones 7 and 9, which are over here. So I'll be going through 2 clips of normal anatomy. This is with a linear probe, and at the very top you see subacute tissue, soft tissue. There's sort of round hypoechoic areas, which are the ribs, with some rib shadowing below that. The bright line sort of going across the screen is the pleural line, and the less bright lines further down are A lines, and that's reverberation of the pleura, that's artifact, that's completely normal. You want to generally see at least 2 rib spaces, and you really want to see A lines going across the lung fields before you call that lung field normal. This is just another clip of normal anatomy, just showing the diaphragm. So again, we have the soft tissue at the top, the rib in the middle with some rib shadowing, the really bright pleural line, some A lines. What's noticeable in this picture is the diaphragm. These are two curvilinear sort of lines going down that will be where you're most often looking for an effusion in a supine patient, which would be right over here. So now I'll be talking about some of the pathologic findings in lung ultrasound, starting off with a consolidation. Consolidation is an area of mixed ecotexture that you want to be really more than 1 centimeter before making any sort of diagnostic considerations for. Less than 1 centimeter, we're still debating in the literature about what to do with, and I'll be peeking in over here on the right. Again, most arise from the pleural line in kids and in COVID-19, so this is the area you really want to be focusing on. On this clip, you also see a very mild pleural line abnormality with a little pleural line break right there, but a better picture is on the next slide. The next pathologic finding we'll be looking at is B-lines. So B-lines are actually only pathologic if there's more than 1 or 2. Scattered B-lines are actually considered normal, but what they are hyperechoic lines arising from the pleural line and shooting down. And they have to reach the way bottom of the screen and erase A lines that go across before you consider it B lines. Otherwise, they're called Z lines, which we'll talk about a bit later. And here you actually see a little bit better of an example of a pleural abnormality where it looks a little bit thicker and there's small little breaks in the line, the pleural line over here. Here we have a picture of an effusion. On the far right, there you could see the diaphragm peeking in and out, the large ribs, and in between is a hypoechoic region where an effusion is. And it's, again, generally right above the diaphragm in most supine patients and the most dependent regions, which is generally the posterior basal areas. So lung ultrasound has a lot of pearls, but also has some pitfalls, particularly in COVID-19. There's really no pathognomonic feature that you can look for in lung ultrasound for COVID-19. Like, yes, you get a lot of non-specific B lines and lots of pleural line abnormalities, which are all by far the most common. And you can see consolidations, and they're generally subpleural, and you can get effusions. These are less common. It's generally the entire pattern that you're looking for, and you can sort of assess how bad the pulmonary disease might be based on lung ultrasound, but it's sort of hard to immediately diagnose COVID-19 based on lung ultrasound since there's really nothing that points directly to it. For other diseases, not just COVID-19, lung ultrasound works amazing for it. For pneumonia, it has a sensitivity of 96% and a specificity of 93%. You can very easily look for effusions, particularly in the dependent regions like we saw before. Something to sort of look out for, though, is that Z lines don't necessarily equal B lines. Z lines are hyperechoic lines that arise from the pleural line but don't quite make its way all the way down to the bottom. And I find a lot of people who are sort of new to lung ultrasound see one or two B lines and think it might be something abnormal, but really it's okay to have a couple that are fairly scattered and aren't like condensed into one region. And anything with lung ultrasound or anything with ultrasound in general is operator dependent. So you really do have to there is some learning curve to it. And small children don't love to be held down and have cold gel on their chests, so some are less likely to tolerate it. You can try using warm gel and having parents hold them in a position of comfort with child life or someone else providing distraction. So in a peri and post-COVID world, there are a lot of pros and cons to lung ultrasound. I mean, the pros are pretty obvious. You can minimize PPE and exposure for other staff in the hospital, particularly the X-ray techs. You avoid transporting the patient to another area of the hospital or bringing a large X-ray machine into a room. It can be used both on initial presentation of the patient and frequently done very safely for reassessment. It's really easy to disinfect compared to a big X-ray machine. The cons are that lung ultrasound isn't quite very specific for COVID-19, and if you see a consolidation, it can be a little hard to tell whether or not it's atelectasis and a collapsed lung from a viral process or some other inflammatory process, or if it's a true bacterial pneumonia. Like we talked about before, younger patients can have a harder time tolerating the procedure, but again, as long as you have a parent that's willing to hold the patient, have good distraction, it's usually not an issue and it doesn't add too much extra time to the exam. There is a learning curve there, and I find that the buy-in from other parts of the hospital can be a little tough. If we don't obtain an X-ray, they generally don't feel as comfortable with just me saying my exam findings. So let's start off with our case. This is a 17-year-old obese male with a history of asthma who presents with 5 days of chest pain, dyspnea, and fever back in May of 2020. Parents tried albuterol at home, which didn't help with symptoms. He had a sore throat, emesis, and diarrhea, and was sick, but we're not sure of her COVID status. When he came in, he had a temp at 99.4, heart rate in the hundreds, respiratory rate in the high 20s, and O2 stat of 88%. He was in moderate distress, but otherwise awake and alert, speaking in full sentences. He was tachypnic with shallow breathing, no crackles, and a mild wheeze, but good air entry. He had no murmurs, no rubs, no gallops, and he had a soft, non-distended abdomen, and he had some acanthosis around his neck. The differential for this patient includes, his history of asthma, so an asthma exacerbation, a pneumonia, a viral illness with a sore throat, his vomiting and his diarrhea, with his chest pain and dyspnea. You think about a mediastinal mass or pneumothorax, maybe a myocarditis or a pericarditis, or congestive heart failure or cardiomyopathy, or a metabolic derangement such as DKA. So we performed a lung ultrasound. He was a larger patient, and so we had to use the curvilinear probe. He had a thick pleural line, you can see over here. He had significant B lines, which sort of shoot down and again erase any sort of A lines. And they almost look confluent, so they almost seem to come together and take up the entire rib space. This is another clip of the patient that shows a very, very trace effusion. I'm on his right side and fairly high up, so at first I was not sure if this was liver or if it was a large consolidation, but I put Doppler on, which unfortunately I don't have the images for, and saw flow in these hypoechoic areas, and so I thought it was more likely to be the liver. And you could make out the diaphragm here with a very, very trace effusion right above that diaphragm right here. So his labs and imaging were notable for a white count of 6.54 with 79% neutrophils. He had significant inflammation with an ESR of 101, a CRP of 22.9. His gas was notable for a pH of 7.49 and a PCO2 of 48 with a bicarb of 25. COVID was detected on PCR. He had an EKG and a trope that were both normal. We did still obtain a chest x-ray, and it noted increased opacities throughout the lungs with no large effusion, and the impression was findings compatible with ARDS. So we tried Duodev, steroids, and magnesium, but didn't really get a large response in his work of breathing. He was then placed on high-flow nasal cannula in the emergency department and admitted to the ICU. He got worse, unfortunately, over the next 48 hours and needed to be started on a BiPAP. Remdesivir was then started after ID was involved with expectation for a 10-day course. He also received ceftriaxone for 7 days given his degree of severe illness. He was briefly on TPN while in the ICU and was given Lofenex for DVT prophylaxis. Eventually, he was weaned off all respiratory support for the next 2 weeks and was discharged to home. So in summary, lung POCUS can quickly and safely diagnose lung pathology, reduce exposure of hospital staff and other patients to infectious disease, except of course a sonographer. And this can help to minimize chest x-rays and subsequent radiation. And it's also easier to clean and has a smaller footprint in the hospital. However, there's still like a large variability in the presentation and lung ultrasound findings of COVID-19 pneumonia. There's really no pathognomonic findings, which means that you have to take the lung ultrasound sort of in context of everything else with the patient. That being said, there's still a high sensitivity and specificity for pneumonia and an effusion. So if you're not sure if this is more of a viral pattern or if it's bacterial that might need antibiotics, it's a great choice. Knowing that most consolidations are subpleural, and B lines and some pleural line abnormalities are by far the most common findings. We are still figuring out what to do with small consolidations, but stay tuned. This is me. These are my references. Thank you for listening.